Welcome back. It's my pleasure to introduce Miriam Solomon from the Department of Philosophy at Temple University from my former home state of Pennsylvania. She's here to talk to us about after disclosure.
So I'm very happy to be in Canada, and I would like to thank Claudia and everybody at the Rotman Institute for their hospitality and for how wonderful the conference has been so far. Before I start, I'd like you to lower your expectations a little. The first thing is I've just had a lovely lunch, and my blood flow is in my stomach and not my brain. But the second thing is, this is a small piece. Alan Franklin said yesterday that, some of the work we do is in the form of big pieces, but the important thing is to keep going with the small pieces. And this is a project that I hope adds something to the current treatment of pharmaceutical bias. But it isn't radical. I hope it's sensible. Okay, I'm going to start with a claim that is from the literature. I'm not going to try and justify it here. I'm just going to try and address it. Industry funding of research is the greatest known systematic threat to the objectivity of medical research. This is a pretty strong claim. It's based on the work of medical researchers who've systematically compared the results of industry-sponsored research and not industry-sponsored research, and that this study is on the left-hand side. I should mention that the word objectivity up the top can be interpreted in a traditional way as freedom from bias, but it can also be interpreted in non-traditional ways, such as in my own work in social empiricism, when bias is not viewed as fatal to scientific reasoning or decision-making, even if we use more generous accounts of objectivity. It could be my account, could be Helen Longino's account. It's still a problem because pharmaceutical company bias always skews the results in the same direction. It's systematic. And it skews them in the direction of the interests of the sponsors. Industry now funds more than half of biomedical research in the USA. Public funding about a third, and the rest comes mostly from private not-for-profit universities, foundations. Most industrial medical research is research into pharmaceuticals, and I'll focus on this, noting that the situation with medical device research is thought to be similar, but that's a smaller body of research and there isn't as much evaluation of it. So the task of the paper is to clarify the nature and scope of the bias, to attempt to quantify it, to evaluate the remedies for the bias suggested so far, and to propose 2 possible further interventions to reduce the effects of industry bias. So no magic bias remover, but step-by-step approaches. Research that's funded by for-profit industry is substantially more likely to yield results that are favorable to industry than research that's funded independently. Industry bias, funding bias, and pharmaceutical company bias are widely used terms to describe this systematic skewing of results. And now moving over to the other side, where there are extended book-length treatments. Marcia Angel, the former editor of the New England Journal of Medicine, was one of the first to sound the alarm about pharmaceutical company bias, and her 2004 The Truth About Drug Companies How They Deceive Us and What to Do About It is just one of several books that have come out over the last 15 years. Others include Sheldon Krimsky's Science in the Private Interest: Has the Lure of Profits Corrupted Biomedical Research? David Resnick's The Price of Truth: How Money Affects the Norms of Science. Ben Goldacre's Bad Pharma: How Drug Companies Mislead Doctors and Harm Patients. David Healy's Pharmageddon, and Peter Ghoce's Deadly Medicines and Organized Crime. Major medical journal editors, including Marcia Angel, also Richard Smith of the BMJ, and Catherine DeAngelis of JAMA, have been particularly prominent critics of pharmaceutical company bias. Richard Smith even titled an essay in PLOS Medicine, "Medical journals are an extension of the marketing arm of pharmaceutical companies." The tone of most of these books and essays is one of moral outrage, framed as the pursuit of money getting in the way of the pursuit of truth, and even more egregious, the pursuit of money getting in the way of the health and safety of patients. At first, the main concern was the incidence of overt research misconduct, such as fabrication of data and concealment of adverse outcomes. That is, industry bias was thought to be the result of intentional dishonesty and deception. There were some prominent cases involving misconduct, such as fabricated and misrepresented studies of Vioxx and the concealment of adverse effects for Risperdal. But most cases of industry bias do not appear to involve such misconduct. Nor is it the case that, generally speaking, industry research has worse or sloppier methodology than independent research, at least as measured by our standard measures of methodological quality, such as the consort standards and the journal standards, and so on. Several studies have found that, in fact, industry research is of a methodological quality equal to or greater than independent research. The problem is not primarily so-called bad science that results from sloppy methodology or fabricated data. Even with an apparent commitment to honest and high-quality research, biases still operate. The so-called replicability crisis, the failure of clinical trials to produce the same or statistically similar results when repeated, and here I'm thinking of Ionides' research, is attributed, at least in part, to pharmaceutical company bias. It's not the only cause of the replicability crisis, and others here do speak to that. At least some of the causes of industry bias are well known. They are selective publication of positive results, multiple publication of positive results, weak control arm dosages, excessive use of placebo controls rather than controls using the best current treatment, selective reporting of favored endpoints, and interpretive spin. Some of this bias operates through explicit decisions and strategic choices, and some through implicit mechanisms, such as confirmation bias. And I'm not really interested in this paper in distinguishing between intentional misconduct, unintentional bias, and all the shades in between. This paper is focused on the epistemic consequences of the bias and not on assessing the ethics. I'm being neutral about how intentional or unintentional this is and where blame or so on. I'm just being very factual. This is what the bias produces. What should we do about it? Okay, let's move on to the magnitude of industry bias. In an absolute sense, industry bias is modest. No grand cures of formerly intractable diseases are being claimed. Rather, claims are typically run-of-the-mill, of the kind more effective than current treatment, or more effective than placebo, or just as effective with fewer side effects. The problem is not the absolute size of the bias, but the fact that the bias produces results that are of comparable magnitude to the effectiveness of most of our medical interventions. So the bias is about the size of the expected benefits. So that's why it's a problem. It's not just that there's bias, but it's the relationship between the magnitude of the bias and the magnitude of expected effects. Most pharmaceuticals have modest and variable effects. This is why we need large, double-masked, randomized control trials to discern their effects from those of placebo and noise. Indeed, if effects were large and consistent, large, double-masked, randomized control trials wouldn't be possible because the results would quickly unmask the intervention. There have been a number of attempts to quantify the likelihood of pharmaceutical company bias by comparing the results of studies having industry sponsorship with studies funded independently of industry. And now I'm going back to some of the studies that I had earlier earlier posted. So the Beckelman study, which is from 2003, found an odds ratio of 3.6 of the ratio between the likelihood of positive results with and without industry sponsorship. Lexchin 4.05, a study by Flacco in 2015, 2.8, and a recent Cochrane review with many papers found an odds ratio of 2.05. And all the studies have 95% confidence intervals. The authors of the Cochrane study, which is the most recent one, note they find a little less chance of pharmaceutical company bias than in previous studies. They argue that it's unlikely to be because pharmaceutical industry bias has decreased. Instead, they believe their study is the most rigorous. For the purposes of this paper, it's not necessary to agree with them about this. I personally, ever the optimist, think it's possible that pharmaceutical industry bias has decreased due to increased oversight. It's another possible interpretation of the differences in the data. But we can proceed by noting that all the measures of bias have been substantial, and previous measures of the amount of bias have been higher. One caveat that somebody pointed out to me should be mentioned. It's possible that trials funded by industry are in fact more likely to be effective than trials funded by universities or governments. Perhaps, for example, industry is more likely to fund trials at a later stage of the development of a pharmaceutical when it's already shown some promise. The Cochrane study denies that this is the case based on its familiarity with the data, and I'm going to go with this while noting that some people might want to look at it in more detail. So here are some proposed remedies. Yes?
Is there a difference in the degree of bias when studies are carried, when the sponsors are designing a study to carry out before and they're looking for a treatment that they might use later, or when they're carrying out a study of something they're already selling after the fact?
I believe most of this data is about before. This is pre-approval studies.
Can I just add something to that? I think
you guys please use the mic?
I'll speak very loudly. This is just to add to this last remark. There's actually data supporting both, because even in reviews of existing things, like say, what's the best blood pressure medicine and somebody will review it. It turns out that if you are paid by the industry in the form of perks, your favorable rating is much, much higher than if you're truly a neutral person.
Yeah, and that tells you that systematic reviews are biased as well.
Yes.
And sometimes they require meta-analyses, which again are biased as well. So a lot of the steps we've taken towards formal aggregation of evidence don't seem to be immune to this kind of bias. So anyway, there are 4 proposed remedies before I give mine. And I'm going to talk them through, and I think they're all good. They're just not enough. Disclosure was the first remedy, and that's why I called this paper After Disclosure, because disclosure was the first thing people thought was needed, and somehow they thought it would do the job. Journals started requiring such disclosure in the 1980s. Here is a statement from the AMA in 1990. Perhaps the best mechanism available to assuage the public and professional doubts about the propriety of a research arrangement is full disclosure. The disclosure should be made to the medical center where the research is conducted, to organizations that are funding the research, and to journals that publish the results of the research. The International Committee of Medical Journal Editors, which issues recommendations that are accepted by more than 600 medical journals, has a standard form for such disclosures. The current disclosure form requires full disclosure of the sources of research funding, as well as any other financial relationships of the author or the author's institution with industry. The idea behind disclosure is that the readers of a journal article will have information about conflicts of interest that they can take into account when evaluating the article. Why does it seem like an obvious remedy to address conflicts of interest? The answer is, in fact, not obvious. If we look at the language of the AMA statement, it seems more concerned with ethical propriety than with correcting bias. It makes it sound as though the main problem is non-disclosure of the funding, which is viewed as deception that undermines trust in research results. But the main problem from an epistemic point of view is that industry funding, whether disclosed or not, biases research outcomes. The AMA statement does not make explicit, perhaps it was not thought to be necessary, that when industry funding is disclosed, readers of a journal article can adjust their confidence in the results appropriately. The journal article with a proper disclosure does not mislead, it just leaves the work of discounting to the author. As a moral intervention, disclosure works to prevent deception and restore trust, at least for most readers. The reader is told what they think they most need and ought to know. As an epistemic intervention, however, it's only a first step. How much should we discount? And do we, in fact, do the discounting? The current answer to this is disappointing. To my knowledge, there have been no discussions of exactly how much discounting there should be for industry-funded studies, either individually or in meta-analyses. The work is entirely left to the reader of the journal article. For individual trials, the reader has information regarding trial funding, but for meta-analyses, information about trial funding is currently left out of the analysis and therefore inaccessible to the reader. In meta-analyses, a randomized controlled double-masked trial funded by a pharmaceutical company is almost always ranked as higher quality evidence than an independent, high-quality observational study. While readers often claim that they discount the results of industry-funded studies, recent evidence suggests that they don't discount them at all. never mind discounting them by the right amount, whatever that is. A 2010 study, a Silverman study, on hypothetical willingness to prescribe a new drug based on the evidence and a disclosure statement suggests that physicians do not discount at all for conflicts of interest. There's also a finding that disclosure may have perverse effects on both the researcher, the author of the paper, and on the reader. And this is a Lowenstein study in 2012. It finds that researchers sometimes exaggerate their findings in advance to counteract the expected discounting after disclosure and feel morally justified in so doing. Moreover, they find that disclosure can create a burden of disclosure effect in which readers feel obligated to trust what they read even more when the authors have been honest with them by disclosing competing interests. So, the social exchange is not in the interests of better knowledge.
So exaggerate in what way? If they collected more data, that would be good, but you're talking about misrepresenting?
I'm talking that about they exaggerate them in a positive way. That is, they exaggerate how well the drug does. They use rhetoric to exaggerate how well the drug does. Then they feel justified in so doing because they believe that the people who read it are going to discount it. Okay. So disclosure of competing interests is a widely implemented regulation designed to reduce industry bias. It may suffice ethically in that it increases transparency, but doesn't suffice epistemically in that the disclosure does not reliably produce discounting by the reader. We still need to figure out how much we ought to discount industry-funded research, and we still need to implement this discounting while avoiding or correcting for perverse effects of disclosure. So disclosure is a step, it's not a solution. Here is a second set of suggestions: further standards and regulations. Disclosure is not the only procedural recommendation for addressing industry bias. Over the last 30 years of experience with industry and other sources of bias, the research community has developed common standards for the proper conduct and publication of clinical trials. For example, the recommendations of the International Committee of Medical Journal Editors have been adopted by over 600 medical journals. They include disclosure of conflicts of interest, but also specific criteria for authorship, trial registration, accessibility of study data, peer review, editorial freedom, and constraints on duplicate publication, sponsorship of special issues, and relationships to advertisers. Other recommendations address methodology. For example, the consort statement, endorsed by many medical journals, gives standard recommendations for the conduct of randomized controlled trials. And the JDAD scale, which is the Oxford Quality Scoring System, is a widely used quantitative measure of trial quality. The standards include requirements for trial registration, statement of initial objectives and hypotheses, measurement of the attrition rate, documentations of any changes to the conduct of the trial, and requirement for the full trial protocol to be accessible. The Journal of the American Medical Association takes these requirements even further, insisting on independent statistical analysis with both trial protocol and raw data posted on websites. These standards and regulations are most important. They are designed to reduce or eliminate many sources of bias, including industry bias. They've been developed over the past 30 years in response to specific known sources of error. Without them, we would be in a much worse position when assessing the evidence for a clinical intervention, and there would be many more ways to compromise research quality without discovery or consequences. However, as I mentioned earlier, our current measures of trial quality find that industry-funded research is of equal or higher quality than non-industry funded research on these measures, even while industry bias is still present. The Cochrane study, for example, finds that as measured by 4 common standards: sequence generation, allocation, concealment, follow-up, and selective outcome reporting, industry-funded research has the same risk of bias, and it has a lower risk of bias from the 5th common standard, blinding, which apparently does even better than non-industry funded trials. But it has a higher actual bias in outcome assessments. So there's a real difference between the risk of bias and the actual bias. This is thought to be because industry has been mindful of the need to be perceived as producing high-quality research and quick to direct its substantial resources to comply with the publicized standards. This finding suggests that standards and regulations are not in practice strong enough to safeguard against the industry bias that currently operates. In some cases, for example, selective publication of positive results, this is because of lack of enforcement of standards of reporting of negative results. Trial registries, at least in the USA, are often left incomplete when results are negative. And the website clinicaltrials.org, which is supposed to, in which people are supposed to register their trials, is full of old trials where the reports have not been posted and there's just no enforcement. Moreover, will anyone notice if there is selective reporting of favored endpoints? So, how much checking is done? In other cases, for example, the use of weak control arm dosages that make the product look better than it should, it is because standards have not yet been devised or cannot be devised to avoid the techniques of the industry trade, especially in those areas in which there is room for, quote, scientific judgment. It's going to be difficult to operationalize regulation of research. These areas include choice of control dosages, choice to use placebos rather than active controls, inclusion and exclusion criteria, and interpretive spin. If the standards and regulations don't do the job or are not implemented well enough to do so, perhaps biasing strategies could be caught in peer review. Richard Smith, the BMJ editor, quite reasonably doubts that this is the case, and he says, there are many ways to hugely increase the chance of producing favorable results, and there are many hired guns who will think up new ways and stay one jump ahead of peer reviewers. Bennett Holman, the philosopher, refers to the situation as an asymmetrical arms race in which one side is driven by truth and the other by money. It's a situation rather like that of computer virus prevention, with the virus creators always at least one step ahead of the antiviral software engineers. If this is the case, then some pessimism about the elimination of industry bias is justified. Keeping one step ahead all the time is going to be hard. But it's also reasonable to view the situation as one in which regulations and standards are already reducing industry bias and in which improvements are still possible. So when I put up the original statistics about the magnitude of pharmaceutical company bias, The Cochrane Review of 2017 finds less bias more than 10 years after previous measurements. And this may be because they have a more rigorous methodology, as they say, or it may be because the magnitude of publication bias has decreased due to regulation. Over time, if we keep measuring industry bias at regular intervals, the trend, if there is one, should become clearer. The third suggestion, independent sponsorship of clinical research. This is the most commonly suggested remedy. It is to propose that most or all of clinical research be carried out independently of industry funding. Usually, such proposals are accompanied by the practical recommendation that clinical research be carried out by governmental organizations that can be funded through a tax on the industries that develop the interventions. This remedy has been suggested from the beginning of awareness of the magnitude of industry bias to the present. And if you think about the books I mentioned early, all of them seem to take this attitude. So Marcia Angel, Sheldon Krimsky, Sergio Sismondo, Peter Gocci, and others all suggest that we move to independent clinical trials. I think Yves mentioned that yesterday. So these suggestions address the problem of industry bias by proposing to remove it. It's somewhat drastic in terms of regulation and institutional reorganization, but it preserves a traditional ideal that much, most, or all of research should be, quotes, free of conflicts of interest. Going forward, it proposes that medical research should be both epistemically and ethically unsullied, at least by conflicts of interest. These suggestions come up frequently, yet no steps have been taken to implement them, at least in the USA. They would take a good deal of bipartisan political will to implement, and such will is in short supply at the moment. Even if the suggestions were implemented, the revolving door between industry and government means that the same individuals will spend time in both industry and government, making it likely that their interests cannot be kept pure. As with the other suggestions for reducing industry bias, partial implementation of the idea is likely to make a difference. Increasing independent sponsorship of clinical research is valuable, even if the ideal of all clinical research being independent cannot be realized. Certainly, this suggestion can be part of the response to the problem of industry bias. So, some people have proposed, for example, that at least one of the 2 positive trials required by the FDA for approval of a product be produced in independent testing. And the fourth category is case-by-case assessments. This is a proposal in an article by David Resnick and Kevin Elliott from 2033, and it's a fairly nuanced approach to assessing the impact of financial conflicts of interest. They recommend against discounting all research that has financial conflicts of interest simply on the grounds that such conflicts can produce biased research. Instead, they suggest considering 5 factors that vary from case to case. The first is whether researchers, sponsors, or institutions have a financial stake in the outcome. The second is whether the financial interests coincide with the epistemic goals. The third is whether the researchers, sponsors, or institutions have a history of biased research. The fourth is the ease of manipulation of the research to achieve financial goals. And the fifth is the presence of oversight mechanisms, such as prior registration of clinical trials, that can minimize bias. For example, an industry that has a strong record of replicable research and effective interventions will not need to have its current research discounted. And an industry with a history of biased research that has not pre-registered its current research will deserve to have its research discounted. There's a lot to be said for this proposal. It avoids the perhaps overgeneralizing conclusion that all industry-funded research is biased. Instead, it says that such research may be biased and needs to be investigated for bias, but may turn out to be unbiased. This is more just. It doesn't tar one industry with the sins of another. And it gives industry an incentive to build its own reputation, each industry, for reliable research. So some industries could develop a strong reputation and thus be less discounted, and other industries be more discounted. The downside to this proposal is that doing a 5-factor assessment for each piece of research is quite labor-intense, and it requires information that may not be easily available. And who's going to do it? It may not be feasible to do it for every single study, although it is perhaps feasible to do it for the occasional study or for a particular company. Resnick and Elliott also don't say who should do the assessment and at what point, before or after publication. The 5 factors considered cover known sources of industry bias. However, there may be other sources of industry bias that we do not know about, and if that is so, Resnick and Elliott's proposal will not do the necessary work. It's also likely that the 5 factors will need to be supplemented with additional criteria as some industries develop new strategies to maximize the chance of favorable outcomes. As with guidelines and regulations, there is the possibility of an arms race. My main concern with Resnick and Elliott's proposal is that in their attempt to assess each company on its own merits or demerits, they lose sight of the fact that the overall impact of industry funding on research is in the direction of biasing the results towards positive conclusions. We even know the magnitude of the bias, an odds ratio somewhere in the range of 2 to 4. In the absence of a 5-factor assessment, it's most reasonable to treat industry research as biased, not as innocent until proven guilty. Of course, this has the downside of doing an injustice to less biased research and perhaps removing an incentive for industries to improve the reliability of their research. Let me move on now to my suggestions. At this time, I believe there's a need to flag all medical research funded by industry because the biases are so persistent. I propose calling industry data I data, that's the I data, and then there's a regular data. And industry results, I results. This tag should stay throughout any systematic review and or meta-analysis so that industry bias is taken into account while aggregating the data. My first suggestion is for a qualitative discounting of I data and I results. They should not be included as level 1 evidence in evidence hierarchies because they're much more likely to be biased than independent research. Only independent randomized controlled trials belong in level 1 evidence. Perhaps you could put them in level 2 evidence along with observational trials, which are good but not quite as reliable as randomized controlled trials. Maybe lower, because actually observational trials are better than expected. That's a suggestion for a qualitative discount. So somewhere further down on the pyramid of evidence hierarchy. My second suggestion is for a quantitative discounting. That is a quantitative penalty to correct for bias, not to eliminate it. The idea is to adjust the results using the inverse of the most recent odds ratio measurement of industry bias. For example, suppose that an industry-sponsored randomized controlled trial of a new drug reports a result that the drug makes relief of pain 3 times as likely as placebo. And suppose that the most recent odds ratio measurement of industry bias is the Cochrane one. That is about 2. Then the adjusted results will be 3 multiplied by 1 over 2 equals 1.5, a much more modest result. This adjusted odds ratio might be more appropriate for use in meta-analyses in which the results of both industry and independent research are combined. So this proposal, for which I thank John Clark for the technical elements, would provide an incentive for pharmaceutical companies, at least those who are in it for the long term, to collaborate to reduce bias, because we're going to use whatever the next Cochrane review measure is of industry bias as a whole. Alternatively, particular companies, those in it for the long run, could strive to establish independent records of reliable research and then receive less discounting of I results in return. There is a possibility that such an intervention will backfire, in the same way as disclosure may have backfired, by encouraging companies who feel penalized by discounting to feel licensed to exaggerate their results. Well, they penalized us, but this was, our result. Another unwelcome outcome would be the removal of an incentive for some companies to improve the reliability of their research if they think no one else is going to do it. Perhaps the only way to prevent these outcomes is to encourage companies to produce more reliable research by rewarding such efforts with less discounting. So really allowing each industry to develop a track record. So I'm aware that this isn't a perfect suggestion, but I'm putting it out for discussion. I wish there was a simple and feasible remedy for industry bias. Because in the current political climate, there's not. I'm glad that so much work has been done already to reduce industry bias through guidelines and oversight. My suggestions are intended to take current strategies for minimizing the effects of industry bias a step or two further. Thank you.
Great, we have lots of time for questions.
That was terrific.
Microphone.
Thank you very much. That was terrific. And I agree with you, but I want to go a step further. And you can say, no, that's ridiculous and hopeless and utopian and so on. There's one thing you didn't include, but you would know about. And that is all of the research you've been talking about has been research that's aimed at IP rights, intellectual property rights, in order to get royalties from Zoe. The mere fact that this is possible skews a ton of research. So if you just take depression, the things like Prozac, take them at face value, seem to help about a third of the people who take Prozac. And there's been a bit of research on the effects of exercise on depression, and you get roughly the same results. About a third of the people get that. Now, no industry is going to put a penny into exercise because there's no royalties to be made from that kind of knowledge. So whatever final proposal we have, it's got to be not only controlling industry from cheating in drug solutions to health problems, but it's got to allow all kinds of other things. Exercise, diet, air pollution, all these things that probably affect our health enormously. So that, I think, needs to be worked into whatever final answer you give. The second thing I want to say, and you'll think it's probably utopian, I think the solution to this is to eliminate IP rights in medical research. Just stop it. I'm not asking for an end to patents across everything, just in this case. And the reason, my motivated reason for this, is twofold. One is so much of this depends on extremely complicated clinical trials, which are not reproducible because of the extraordinary expense. So you have to trust the people who do it. Now you've got ways of taking care of this. The second thing that motivates this is it's dead easy in a country like Canada because we already have socialized medicine. And if I talk to him and say, look, you're thrilled with socialized medicine. Sorry, not you're thrilled with socialized medicine. You're thrilled with socialized medicine. Just put research, medical research, as part of the thing. Take it out of the for-profit sphere, which is what 95% of Canadians think that's the way you should treat medicine. So it's a piece of cake, you know, to get them conceptually on this. Americans are going to have a hell of a lot more trouble, I realize that. And it's also going to be trouble internationally because of integrated trade and so on. But I think that's the solution. If you get rid of IP rights, you get rid of the incentive for researchers to look for drug solutions to health problems when they could say, I think there's a better chance exercise would do a better job here. And it would make it more or less biased in that sense too.
I like that. Wasn't it, well, I'm trying to remember what it's called, the Bayh-Dole Act, maybe?
Yeah, Bayh-Dole in 1980, which is, for those who don't know Bayh-Dole,
Microphone.
For those who don't know Bayh-Dole, it just changed the character of medical research. In 1980 or 81, the US government always funded research, and anything that it funded had to be in the public domain, no patents. And then because of, they were afraid Japan was developing far too fast, they had to bribe industry into turning fundamental research into profitable products. And that was the point. And that meant that if you got US taxpayer money, you could patent the results. And all of a sudden, it just changed the character of, especially of US medical research.
Yeah.
You're right, that's the fundamental change, politically. Wipe it out. Just take it away and go back to pre-1980.
I'm doing my best.
Yeah.
I vote.
Yeah.
Thank you very much. There's one aspect which is the epistemic aspect, and I think it should not be that difficult to do. As you mentioned, most of the time, I don't know if there's a different person in Canada and the States, but I don't think so, because Canada tends to just do what the States does and just apply the result the NIH decided most of the time. And but when they do those clinical things, the most obvious problem, which is easy to solve, is the fact that they choose to compare their new thing with placebo instead of, as you exactly mentioned, the best available one. We should just simply force, that's it. Every place where, and it's most of the place, because as we know, it's saying also to patent, to extend patent by just adding a small thing. So if the law just simply says, you test against the best available. So if we cannot do even this very easy thing, all the rest is just in our dream. But I think the reason why it's worth pushing again, the fact that, because I know perfectly that saying that all the things should be done, it's in the dream. But why is it strategically to say it in public? Is that continuing to say that will force people to say, oh yes, there is a real problem. I will give you an example. There was an editorial in the newspaper in Montreal a couple of months ago. And so she said, oh, there is a problem with this. But then there are those people that said, oh, yes, it's a bit not practical, though I think it's practical. It's just a decision to be made by the state. It won't be done. But the fact that we continue to say that, we're forced to find other things. Because if we have your fifth approach plus the other one, because none of those are in contradiction, I think, to each other. They all go in the same direction, and they try to solve different aspects without adding a magic bullet. But if we at least push one point at a time, like just forget the placebo, except where there is none, which is less and less, because if we win this one, already you will see that the expected will be 1.0 and things like that. So you should do that and add to this step, including scrap the placebo test.
That would
That's
be
a
that would be
strategy thing.
really good. What I worry about is the drug company pushing on that, because in order to tell whether a drug is better than the currently used, you need a much higher powered trial, and the drug has to do better. So it's much less likely to be successful.
Exactly.
Um,
Exactly. So we have to push that because that's epistemic. Said you want real knowledge, the only real knowledge is against the best, and the social knowledge is the fact that we already have that pill. It works quite well, but you don't do any money anymore because the patent is finished. That's
Right.
the problem. Yeah. Okay.
Hold on, Bill. We'll get you.
Oh, here.
I like your idea. What I think would make it maybe a little more effective is if it was similar to the way that in Canada we have warnings on smoking, like tobacco boxes. So if you took the kind of data that you're talking about and in that label system and you enforced, perhaps through law, that on the packaging for the various medicines, they had to include a little blurb saying this has a rating of an I rating, or this has whatever. And the point of doing that is the general public is not reading medical research journals, and this is only really kind of addressing the scientific community, which is valuable, but if you want to get the companies where it really hurts, you have to get them
Interesting.
in the wallet. So if their customers are seeing, hey, this medicine, for years, I can look at a box and it says, studies have shown to be whatever, efficacious. If I now see, oh, I better actually discount that, even at a consumer level, then I think companies will have to perk up and maybe change their behaviors a bit.
That's a good point. I was actually thinking not only of research scientists, but of primary care providers. That this was like such a simple idea that, you know, you could ask, is this all eye data? And if it was labeled as such, it would be easy to see. And it wouldn't take the amount of research that currently it takes. But yeah, for the general public as well, I see no reason why not. Bill.
Related to
Doesn't matter
this.
which order I saw it.
I just want to give you a personal example of not a placebo, but alternative. I have atrial fibrillation, and it was found out when I had to get a pacemaker for other. And after my pacemaker was installed, I was invited to participate in a study. It would be for 4 years. And in the study, there would be random samples of a particular new blood thinner, which I happen to think is very good, and aspirin, which is a standard good blood thinner. And I wouldn't know which I was taking. And then 4 years later, you know, now, and they also said that if at some point the atrial fibrillation got really bad, then they would put me on the proposed new one. But it was but then I don't know who funded this study, but I was invited to participate in it, and it was definitely not, you know, merely going against a placebo. It was going against the best standard thing. And I was very impressed with it.
Well, I'm not impressed with the lack of equipoise. If you're doing badly, they'll change your medication. It means that they thought the other medication was better. And if they thought the other medication was better, then they didn't need to do the trial.
That the people who were inviting me to do it thought the other medication was better, but they wanted to actually get data to back it up, I imagine.
Well, would you like to be, I mean, this goes back to the AIDS trials in the 90s and the refusal of that community to act as guinea pigs. So, you know, if there's not equipoise, then you probably are better off doing observational trials than randomized control trials.
I have to admit, I decided not to do it.
We have a couple of bottles of window back here.
So thanks, Miriam. I enjoyed your talk, and I find it persuasive, as you can imagine. This question was sort of touched on just a moment ago. So the general question I had is, who should be employing this intervention? I think any particular answer to that question will entail like nuanced features of how the intervention actually looks, right? So if it's organizations like the Cochrane Collaboration who are actually involved in using these evidence hierarchies, so like level 1 evidence, level 2 evidence actually means something to that organization, then they might employ this kind of qualitative discounting. But if it's an organization like the FDA, who, you know, the standard for new drug approval at the FDA is just 2 positive randomized control trials, they're not, I mean, in some very basic sense, they're not involved in hierarchy of evidence stuff. They're just taking 2 positive RCTs and then approving drugs. So they would be, I mean, the idea with your proposal, I take it, is that they would be quantitatively discounting. But since you've already alluded to empirical evidence that shows that physicians themselves don't discount even when they're told that evidence comes from industry-funded trials, then arguably it's not physicians who should be doing this discounting. I mean, we have all sorts of reasons to think that average people are bad at doing this kind of thing, right? Patients and physicians. So maybe this is just a kind of suggestion, like really it should be the FDA, really they should be doing the quantitative discounting, not the qualitative discounting. Then one thing that is quite interesting is, given that the vast majority of new pharmaceuticals today have really tiny absolute effect sizes, like risk differences of say 0.01, when you start applying this quantitative discounting, those effect sizes
they just completely disappear.
Yeah. So let me put all that kind of rambling set of comments into a question. Who should be doing the discounting?
Well, Cochrane is what I was first thinking of, but then I read an article a couple of weeks ago in Science that suggests that Cochrane is now called Cochrane rather than the Cochrane Collaboration, but that it's become somewhat corrupted by industry, and they have Gochi, the guy who did he's out. So I don't know what all the details of that are and what it means and whether Cochrane will still be that independent.
Could you say a little bit more about Cochrane? I don't.
So yes, the Cochrane collaboration is a collaboration that gathers results of medical interventions and aggregates data.
So they do meta-analyses?
They do meta-analyses, systematic evidence review. When they don't do meta-analyses, they'll tell you what the level of evidence is for each intervention.
And this is a
And it's an international based in Britain. They have done reports on a wide variety of medical, I mean, that's where I would look first for almost anything, for the treatment of almost anything.
Can I just briefly, so I agree that they used to be the good guys, and then over the last few years there's been changes to the code. So they used to be the kind of, you know, pinnacle of systematic review evidence assessment, but then there's been this crisis that you just referred to in the last few weeks, but it's been building for a long time. So there's really good reasons to think that they're not independent from the industry, right? So why not just regulators? Like, why not just beef up the FDA or the new drug approval?
And that would be totally fine. I just don't think there's the political will. I'm more worried about the FDA than Cochrane. The other suggestion, though, that I've heard out there for the FDA is that at least one of the studies should be independent. And I like that suggestion. It's at least an improvement. Another thing I worry about with this proposal is who gets to draw the borderlines between independent and not independent, and what exactly that amounts to.
Yeah,
Thank you for the talk. I think my question is just it's a minor clarification point. So you mentioned with regard to your intervention about qualitative and quantitative discounting. Now, I'm just wondering, so for you to clarify, are you also talking about, are you talking about a degree of discounting, whether qualitative or quantitative, in the sense that, say, for example, you will say maximum discounting is 10 and then minimum discounting is 1, and anything that is discounted over 10 will throw away, and anything that's discounted over 1 will, I suppose, reconsider. But and then a 5 would be, okay, be careful here. So is there any sort of degree to the discounting you're proposing?
So I'm trying to make sure I understand what you've asked. The discounting is just a requirement that they shift the odds of it being and they change the background odds, knowing that it's pharmaceutical industry. There aren't different levels of discounting. Everything's discounted the same amount from industry. No decisions. The reason I like its simplicity is that you don't have to make any decisions about, was this a good company or a bad company? Is it likely to be biased? Just all industry data gets this. I don't know whether I fully understood your question, though.
I think you're on the right track to answer it, so that's good. Thank you.
Rich and then Jan.
So I guess there's a couple of possible problems with your recommendation at the end to discount by a factor of 2 or 2.5 or whatever it might be. So let me just have you respond to possible problems. One is that this is a sort of one-size-all solution. And we in science are used to evaluating individual reports on their merits by looking at all the details. And presumably we wouldn't want to apply some general discounting mechanism that wasn't tailored to a specific study. That's a possible problem. But and the other possible problem is if you apply this after publication, then you would have some 0.05 or equivalent measured report discounted to 0.15 after the fact. Usually, but that might instead apply before the fact when you're trying to publish.
Yeah.
Then you require more data to, but then that has the ilk of a recent proposal that we change the 0.05 criteria to 0.005. Sort of the same idea. And there's many objections to that, some of which I participated in. And the same objections might be made to this, and among other things, if you have bias in data, collecting a little more data to reach a higher criterion, so bias, you might have to solve the problem. So these are possible problems.
Yeah. I think there are different times in the process at which this discounting can take place, and my suggestion here is for the consumer of medical literature. So it's already published. What do I think of it? For the person who's trying to do a systematic review and doesn't know anything else about the details of the study. But yes, another suggestion is that journals simply don't accept industry-funded research without them being held to this higher standard. And I can see people saying that's not fair and blah, 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 blah. So there may be practical problems with selling it. I can see that you've said that. And as for, I like to judge each study on its merits, the evidence points to the fact that people don't do that very accurately. And in particular, they don't discount for this kind of bias, for pharmaceutical bias. they tend to reward disclosure and reward disclosure without penalizing for bias. So doing it case by case is not only very labor intensive, but if it's just being done by intuitive judgments, it's likely to not pick up on the bias.
This is just a follow-up on Jacob's point. First, an interesting, amusing, and alarming anecdote. The US FDA used to keep internal records assessing drugs that they were approving. So they approve, as Jacob said, based on how they do in a clinical trial. But internal, they kept a record of things they thought were just crap, stuff they thought was good, and so on. Now I'm trying to recall the exact numbers, and this is just roughly. Roughly 10% they thought was really good and new. Roughly 15% was significant improvements of old drugs that were pretty good. And about 75% was just crap. If it wasn't harmful crap, it was useless in the form of Me Too drugs that are copies of things that are out there but snuck under the rules and so on. They used to keep this.
Who's they?
US FDA.
No, I know, but which people exactly?
Well, it was on their website up until, wait, here's the thing. They used to keep this on their website. It was publicly available. But as you can imagine, pressure from the pharmaceutical industry got it taken down. This was during the Bush administration, so it no longer exists. But one thing about it that was particularly interesting, and I like it because it supports my anti-patent view, and that is in 1 year, which was a pretty typical year, of all of the things that they approved as either new or an improvement, not a single one was produced by a commercial pharmaceutical company. All the good stuff was produced in universities or non-profit funded stuff.
Interesting.
It was the commercial-free stuff. That's where the good stuff is coming from. And the dangerous crap is coming from the pharmaceutical companies. I remember having a dinner with Sheldon Krimsky once a few years ago, and he told me he personally, I think it's okay to say this, he told me he personally won't take any drug developed since 1980, since the Bayh-Dole Act. He just doesn't trust any of it.
That's very interesting.
Yeah. It's doing well. Yeah. Well, there are actually some really interesting government-funded meta studies that show that overwhelmingly Americans take blood pressure medicine that's bad for them. The best blood pressure medicine was the old water pill developed in 1920 or something like that. And that's best for about 80% of the population, but hardly anyone takes it. They take these really powerful things with horrible side effects, but they pay a hell of a lot of money for it. The water pills cost about a penny a day, I think, if you were to take.
Well, if you haven't already read Jacob's new book,
Yeah.
Medical Nihilism.
Yeah, you talked about that example. Wonderful. Okay. Anyway, now the problem about who should look after this. Why can't it be? This is just an off-the-cuff suggestion because I never thought about it before. Why couldn't it be just specialized groups? There are like if you talk to surgeons who work on throats or something like that. There's a best practices. Here's what you do in this case. Here's what you do in that case. Why couldn't it be like that for drug use? And the reason that would be a good thing is if you're worried about people who are worried about depression, they're not going to focus on best drug for depression. They might include the possibility of exercise as the best approach to a particular case, and they'll have a best practices for various situations.
Well, ideally our psychiatrists would be that open, but I just think they've been thoroughly corrupted by industry themselves, so they're not.
But if industry didn't have any power, financial power, they wouldn't be. Oh, I have one more wonderful anecdote. I don't know if people know this, but if you wanted a job working as a drug salesperson, what's the best item to have on your CV when you go to Eli Lilly applying to be a drug salesperson?
Cheerleader.
Yes, cheerleader.
I knew.
Am I asking a final question? I don't know. Sorry, I hope I'm asking a silly question. So I was actually convinced by your idea of quantitative discounting, but my question is about qualitative discounting, that part. Right, this is a silly question. I was wondering, do you have an exact definition for medical research you're talking, the research you're talking about? I was asking because if the research is about the upstream, more like the biochemical or therapeutical functions or the reactions of the drug or whatever, it's already outside the pyramid of the evidence, if I understand it right. But if it's part of randomized RCT, and how do we distinguish between RCTs funded by industries and funded by other independent bodies or non-commercial bodies? Yeah.
Are you asking the question how we know that a trial was funded by industry?
Yeah, so how do you define medical research and as all kinds of research if it's just say a paper studying a therapeutical function of a drug? That might be just, basic laboratory, the kind of biochemical research, but it is RCT, and then how do we distinguish from, because you mentioned that if we're doing qualitative discounting, the best thing to do is to put the commercially funded results in level 2 or even lower.
Yes.
Yeah. But, okay, so. But if it's the basic,
If it's
just
basic research?
research, it's already outside
That's
the
right.
pyramid.
That's
Okay,
right. It's
then
already
don't have to
outside the
worry
pyramid.
at all. Okay.
It's already outside the pyramid,
Oh,
but
yeah.
but nobody should be treating people based on
No. Okay.
based on basic research.
No. Yeah. Okay then.
Thank you. Just wanted to clarify.
But yes, basic research is outside the pyramid.
Yes.
Because we're just talking about the pyramid of interventions. I don't have a view that evidence-based medicine is about the whole of scientific method or anything like that. It's just if we want to know about how successful an intervention is, then the evidence pyramid is a good thing to use.
Final question? Okay, in that case, coffee is calling. Joining me in thanking Miriam again.